professional surgeons, and this is one of them. So it's a highly prestigious lecture. Previous holders of this lecture will have given this lecture as some of the doyens of surgery in the past. President Bradley, Professor Bradley, Professor Bradley is a distinguished transplant surgeon. He trained in Leeds, did his early training in Leeds General Infirmary. In fact, I was an SHO with him. And had no effect, obviously, on his career. He's progressed so well. But he then went as Professor of Surgery to Glasgow and set up the transplant unit there, and then was brought down to Cambridge in 1994, where he's built a fantastic unit, not just in transplantation, but in surgery, academic surgery in general, and he's a real role model. I'm sure this is going to be an exciting and interesting lecture, I have no doubt, and we all look forward to it. Andrew.
Thank you, President, for those very kind words. It is a privilege actually to be asked by the college to give this lecture, and I'm particularly pleased to give it at the SARS meeting, because I know you're all very interested in renal transplantation. Now, I did try and find out who Sir Zachary Coate was, and there you see a picture of him. He's steely-eyed, actually. I'm not sure what sort of man he was, but he trained at St Mary's Hospital in London and then practiced as a surgeon there for the next 40 years or so. I know him best because he produced this book in 1921, Early Diagnosis of the Acute Abdomen, which I certainly used. I don't think it was the first edition, actually, but I certainly used that. It's still apparently a bestseller, although it's probably got a big section on the CT scanning, I guess. So Zachary Coate was a very distinguished surgeon. He also was a bit of a poet, and he wrote what is apparently the only poetry or poem of the acute abdomen, and the pseudonym Zita. I'm not quite sure what Zita meant, but there you are. He produced that in 1947. If any of you want to acquire a copy, then you can get one from the antiquarian bookshop for about £145. So I'm sure it'll be worth every penny. Zachary Coate was probably better known outside medicine, actually, because he did a very in-depth analysis of the final letters of the novelist Jane Austen, and came to the conclusion that she died because of Addison's disease of the suprarenal gland, probably as a result of tuberculosis. And interestingly, this was a major feature in The Guardian about a month ago, because someone's come up with an alternative view that actually it was probably not tuberculosis as understood, but it was actually bovine TB. But I think the consensus is that actually he was probably right. So there you are. Now, continuing on this sort of bookish theme, the title of my talk is Challenges and Opportunities in Renal Transplantation, and it's in two parts. The larger part one is really all about increasing access to transplantation, which is really the challenge that we face as transplant surgeons. And I'm going to briefly touch on some aspects of improving transplant outcome. Now, this is the most showed clinical slide in UK transplantation for any transplant people here, but essentially it shows the magnitude of the problem. That is that we've got an ever-increasing waiting list of patients who desperately need a kidney transplant. The transplant numbers shown by those blue bars have really stayed relatively static over the last 10 years or so. So as the demand increases, we're not keeping anywhere near up to that, and the problem is just growing ever and ever larger. Now, most of the donors are still so-called brain dead or brainstem dead donors, and these are assessed, and they're nearly always patients with intracranial hemorrhage. They're all in intensive care units being ventilated, and death is diagnosed according to these well-defined criteria. That is, there's an essential precondition. You've excluded things like hypothermia and drugs which may depress conscious level, and then we undertake brainstem death testing, and this is done by intensive care consultants, etc., etc. So this is the standard approach, and these patients are heart-beating donors. They're taken to the operating theatre, and the organs are perfused with cold preservation solution immediately heart, while the heart's essentially still beating. So there's really negligible warm ischemic injury. Although what is now becoming clear is that these organs do suffer from quite the nasty effects of brain stem death. There's a severe hormonal and metabolic crisis which actually undoubtedly damages the organs. Now, the number of deceased brain dead or heart-beating donors has actually gone down gradually over the last few years. And if you look at where we feature on one of these tables which shows activity throughout Europe, I apologise we don't have the American data here, but actually America does pretty well. So the UK is shown in pink there. We have, when this slide was made a year or two ago, about 13 donors per million population. That's less than the EU average shown at the bottom there, which is 18, and considerably less than, for example, Spain, Belgium, Austria, and France. So we didn't do very well as a country for procuring organs from brain dead donors. And partly, or really solely, in response to this, an in-depth analysis was done by a group called the Organ Donor Task Force, and they did a very detailed analysis of activity in the UK and looked at practice elsewhere in the world and deliberated on the problems and how they could be solved. And they published this document in January 2008, and they identified three major barriers to transplantation. First of all, donor identification and referral patterns. Secondly, the whole process of donor coordination. And thirdly, the arrangements which existed for organ retrieval. And they made 14 recommendations. They were all accepted by the government and they're currently being worked through and implemented. And essentially they're around about things like increasing the profile of organ donation to the public, improving transplant coordination, setting up independent and properly funded organ retrieval teams, and various other initiatives. And they predict that with these initiatives, it's expected and hoped that there will be something like a 50% increase in organ donation over the next 5 years. So everyone in transplantation is hopeful to varying extents that this will make a real difference. Now, getting the organs is obviously crucially important, but then you've got to allocate them. And in the case of kidney transplants from heart-beating donors, then the objectives are to try and maximise transplant outcome, but there's a tension there with ensuring equity of access. And a key really is trying to avoid patients waiting unnecessarily long, because it's well known that the longer patients wait on the waiting list for a kidney transplant, the worse their eventual outcome is likely to be. Now, with a view to revising how organs were distributed, because essentially until a couple of years ago, one organ was typically kept locally, the other was put into a national allocation scheme, which was okay, but it wasn't particularly evidence-based. So when my predecessor, John Forsyth, who I think is in the audience, was the chairman of the kidney advisory group, I took over from John. John's mission as chair was to look at the evidence for organ sharing and to change the organ sharing scheme in UK kidneys. And they based their evidence on about 10,000 kidney transplants, and they came up with a number of factors which seemed to influence transplant survival. There were donor factors and recipient factors, and the key donor factors were organs generally did better if they were better matched for the HLA antigens. They did better when the donor was younger, so older donors the organs fare worse post-transplantation. And organs did rather badly if the cold-ischemia time, which is essentially the time that the kidney stays on ice prior to transplantation, when that exceeded 21 hours, then transplant outcomes deteriorated. There are also, of course, recipient factors, but difficult to influence these particularly. And this slide simply shows the two key things which affect outcome. On the left is HLA mismatch. As you can see, as matching between the donor and recipient for HLA is better, then the outcome is improved. And as the match gets worse, then outcome, graft survival shown here, long period, 20 years, gets worse. Even more striking is donor age. So if you're over 60, as some of the people on the front row are, then your organs are really not going to do so well when you transplant, even if you're brain dead.